Good afternoon. I'm Kamanyire. I work within Public Health England's Environmental Hazards Department. It's a pleasure to speak to you this afternoon, and I'll headline straight up front. I'm going to try and do justice to all my colleagues' hard work, which I'm relying on for this presentation. So I'll introduce PHE to provide some context. Essentially, PHE exists to protect and improve the nation's health and reduce health inequalities, and we do this through developing evidence, working in partnership, as well as providing specialist services. We've recently launched our new strategy for 2020 to 25, which has 10 priorities within it. Those principally relevant to environmental public health include air quality, cleaner air, responding to major incidents such as flooding and supporting the response to that, predictive prevention, and surveillance and use of data, issues that are being picked up through this morning. One really key cross-cutting issue is reducing health inequalities, which cuts across all of these priorities, in which we have a high focus on. This is a very busy slide, principally to introduce the specialist centre within which I work, which is the Centre for Radiation, Chemical and Environmental Hazards. And it's really just to focus on the fact that we provide a range of support services around those topics in radiation, chemicals and in the environment in general, around interventions, developing the evidence in the science base which informs our advice across government and agencies as well as the public, and also developing standards both nationally and internationally, and some commercial activity as well. Hopefully not teaching people to suck eggs, but thought it was really useful to introduce the main determinants of health. And this is the World Health Organization's Dahlgren and Whitehead model, which really focuses on the determinants of health and well-being for both individuals and populations. And those really in the centre here are relatively fixed in terms of our age, our sex, and our genetics. However, we have a wide range of modifiable factors, such as lifestyle, the physical and social environment, which we can act upon to improve, or in some cases, which we wouldn't want to do, to impact on health negatively. But the key here is really to work on these modifiable factors to improve health overall. So in terms of environmental public health, we're not solely focused on health protection and preventing exposures to individuals. We also work hard to optimise the environment to encourage healthy lifestyles. Why does this matter? The environment's a major contributor to morbidity and mortality, and I think it's been touched on already today. Around 25% of global deaths are linked to environmental factors. This is mainly due to air quality, especially in developing countries. So in terms of environmental pollution, there are a number of factors that are important in assessing the impacts of pollution on health. Environmental monitoring really ties into the top two, looking at the emissions of pollutants and then the resulting concentrations of those pollutants within different environmental components, and we build upon that through various techniques to better understand the exposure of members of the public to such pollutants and the impact that that might then have on health. So, following on, it was touched upon the scale of the impact from air pollution on health. So, it's estimated that long-term exposure to man-made air pollution has an annual equivalent effect to 28,000 to 36,000 deaths. We have effects both at the short-term level in terms of exacerbating conditions such as asthma and causing morbidity and increased admissions to hospital through coughing, respiratory and cardiovascular diseases. But we do also have long-term effects in terms of cardiovascular endpoints, stroke, respiratory conditions as well. So, in terms of air quality, we have concentrations that are measured in terms of nitrogen dioxide and particulate matter, and we make extensive use of DEFRA's automated and urban rural networks, as well as local authority air quality monitoring networks. And this data is then complemented by modelling to enable us to develop public health outcome framework indicators, and principally this one's the indicator of PM 2.5, particulate matter 2.5 micrometers and less, which we then use on the anthropogenic component of this to assess the population-weighted concentrations for each local authority, and we then plot that so that local authorities are then able to use that within their joint strategic needs assessments and to do comparisons with other similar localities to inform policy changes. We do have challenges with that in terms of the timescales over which changes may occur. So these data are updated on an annual basis, but of course we understand that some interventions will take much longer to start to have impacts and effects on that. We have challenges in terms of continuing improvements in modelling techniques. We understand that very often weather will influence a lot of the changes in levels as well. So all these factors add to the uncertainty, but it's still useful alongside other indicators and metrics, such as population levels living within air quality management areas that we use to try and better understand and communicate the impact on health of air quality. Moving on to water, and in this case private water supplies. So this work was done in conjunction with the British Geological Survey, looking at the impact of geology on private water supplies, and principally in this case arsenic levels. Analysis was carried out of 500 private water supply samples, looking at a wider range of analytes. 65 analytes were assessed. And the map illustrates a simplified geological classification with the sample locations with the darker crosses representing concentrations above the 10 microgram per meter cubed arsenic prescribed concentration value. And a lot of this work then identified that around 5% of these samples that were above the prescribed concentration values. But the principal utility of this work was really to develop a methodology to assist local authorities to improve their targeting and exposure assessment for their regulatory function in terms of assessing private water supplies. So it was really just to look at improving exposure assessments based on the geology and prioritising sampling plans for those locations where they were able then to detect the highest concentrations based on geological features and the use of those samples. Moving on to soil. Again, work done by colleagues in BGS, really looking at urban background levels in topsoils, in the shallow subsurface, and this contributes to our understanding of the overall body burden, not just the body burden, the environmental burden rather, of contaminants within the environment. And in this case, it's not formally for formal contaminated land investigations by local authorities, but we also use this data to inform cases of individual exposures. We still do have instances of children who unfortunately do end up with elevated blood lead levels, and really understanding their potential exposures from a range of sources. The overall burden of exposure is enhanced through having access to these background soil levels. And it's not simply for lead, we also have access to this data for polycyclic aromatic hydrocarbons as well. And it really aids that understanding of cumulative exposure from a range of sources. Another area of emerging work is to understand the impact of the microbiome in human health, and that may be tied to soil microbiota as well. There's certainly an interest from colleagues looking at levels of fungi within soil and how that might influence the microbiome overall in human health as well. On to radiation. So the average UK exposure to radiation from an individual is 2.7 millisieverts. Thank you. And the large component of that comes from radioactive radon gas from the ground. So We know that radon is a carcinogen whose exposure and risk is exacerbated through smoking. Geology is the main source, and the map is based on 500,000 measurements in homes across the UK, as well as the local geology, which strongly influences the levels, principally through granite. And it really highlights the variability in the data, so you can have variable levels within buildings themselves, but also between buildings where influences such as heating, occupancy and ventilation can change levels quite radically. And the key is really to understand and ensure that levels are below this action level within homes, and also with below the ionising radiation regulations of 2017 of 300 becquerels per metre cubed. Thankfully, we can mitigate effectively to protect new or existing buildings from radon ingress and really reduce the health burden of exposure to radon. Moving on, as touched on earlier as well, we have an interest in microplastics, and this initial study was looking at microplastics within composting. Colleagues are also looking at release of bioaerosols within composting facilities as well, and plastic might be present within compost due to improper disposal, occasional lack of care of individuals in terms of what they place into their green bins for recycling. And the study looked at the levels of microplastic emissions from an industrial composting facility in the UK, and they did detect levels in air and within the compost samples, and we're looking at different treatments of the compost and how that impacted on the microplastic levels. Certainly for the air samples, the majority of microplastics were predominantly retained on site. I just wanted to highlight that we still have large opportunities to improve our understanding of the impacts of the environment and health overall. We have good knowledge around air pollution, radon, areas that we've touched on, and lead as well. And there's a whole range of factors where the public are much more interested in the impacts on health overall, and we need to strengthen the evidence base, working together to build an improving picture. We are looking again at DEFRA's 25-year environment plan, which proposes a principle of environmental net gain, and we're working within this to understand how environmental public health evidence can build into natural capital work, evidence around the impacts of water, air and land quality, the importance of green and blue space in enhancing health, the use of vegetation to improve air pollution, mitigating noise, flood risk reduction and flood risk measurements, and how we can build health improvement components into that as well. And that will then feed into spatial planning, regulatory activities around environmental permitting as well. It's not very clear, starting to map out again, using the Dahlgren and Whitehead model and looking at how natural capital plays into a range of factors and how they map again across to the co-benefits of building environmental public health benefit and overall public health benefit through natural capital. And finally, we can't do this on our own. We aim to deliver this in partnership, working together with colleagues nationally and internationally across government, but with NGOs, the third sector, and the NHS and the general public as well. And I'll finally just say thanks to colleagues for all their contributions in supporting our work.